And I believe our various participations made it truly remarkable, and we are grateful for your collaboration and your contribution to the success of yesterday's activities. Ladies and gentlemen, I'd like to welcome all of you once again to this meeting. Thank you very much for your patience and your enthusiasm as we want to start the second day program, and we begin with a recap of the activities of yesterday. And to do that for us, I'd like to invite Mayowa from Dawn Commission, who will take the recap of the day one activities. Please just give about 5 minutes for the special advisor to the governor to be here so that we can take the recap of the day one activities. Thank you very much and welcome you to the second day activities. Thank you very much.
straight toward. It is forward ever, backward never. You are going forward, forward ever. Hey, for the Lord has gone ahead of you to make every crooked way straight toward. It is forward ever, backward never. I carry grace, His grace. I carry favor, His favor surrounds me. It's my season of increase. Oh, it is forward ever, backward never. Hey, it's my rock and salvation. Salvation. It's my helper and my anchor. It's my season of increase. Oh, forward ever, backward never. Hey, hey, hey. That's how we move. 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 Oh, it's my season of increase. Forward ever, backward never. Hey, supernatural speed. We move. We move. We move. With the speed of God, we move. We move. We move because it's my season of increase. Forward ever, backward never. Hey, I'm going forward. Forward ever. For the Lord, I'm gonna let you do make every crooked way straight. Forward ever, backward never. Hey, 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 hey. Say, you are going forward. Forward ever. For the Lord, is gonna get of you to make every crooked way straight. It is forward ever, backward never. As far as your eyes can see, you carry grace. Oh, His grace. You carry favor. His favor surrounds me. Hey, it's my season of victory. Hey, say, it's my rock and salvation. Salvation. It's my helper and my anchor. It's my season of increase. Forward ever, backward never. I say we move. We move. We move. We move. We move. We move. Hey, say it's my season of increase. Forward ever, backward never. It's my season of plenty. I say we move. We move. We move. We move. It's my season of increase. Forward ever, backward never. Yes, we move from glory to glory. It's my season of increase. Forward ever, backward never. I'm going forward, forward ever. Hey, for the Lord has gone ahead of me to make every crooked way straight toward. It is forward ever, backward never. You are going forward, forward ever. season of increase. Forward ever, backward never. For the Lord has gone ahead of me to make every crooked way straight over. It is forward ever, backward never. Oh, you are going forward, forward ever. Hey, for the Lord has gone ahead of you to make every crooked way straight over. It is forward ever, backward never.
recommendations and reports from states. Ladies and gentlemen, we appreciated your participation yesterday, and we're glad and we believe today will be another huge success because we have a group of activities lined up for today's program with a view to shaping our future and our collective goals and visions for the region. Ladies and gentlemen, I want to take the... Okay, before then, let me welcome the Ondo State Coordinator of SOCO, Professor Barrister Olaoluwa Bankole, who is joining us today for a special assignment. You're welcome, sir. Thank you. Barrister, you're welcome. Thank you. And also, I can see the Director of Pharmaceutical Services, Pharmacist Lashekon, who is joining us today again. You're welcome, sir. Thank you. And all our executive secretaries, all our directors, and all the participants, welcome all of you to this second day program of this conference. Let me invite Mayowa from Dawn Commission to please step forward and take the recap of the day one activities. A round of applause for Mayowa from Dawn Commission. Reports of the day one activities. Thank you. Please, we need lights here.
Thank you very much. Yes, sir. Good morning, everyone. I will stand on the existing protocol from the MC, and thank you very much for coming to day 2 of the Southwest Regional Health Roundtable. And I'm sure we had a very impactful session yesterday from the 2 presentations from Dr. Okunla and Mr. Mohammed Okore from World Bank and UNICEF, then also our state updates as regards health insurance in our states within the region. So I'll be taking a recap of yesterday's session, starting with the key points from Dr. Okunla's presentation, attaining universal health coverage through a strengthened health insurance system. Some of the key challenges he identified were that Nigeria faces a significant health system challenge with dire statistics. That 6th lowest globally on the Human Capital Index, were among the bottom 5 globally for maternal mortality, infant mortality, under 5 mortality, and life expectancy. 202.7 million population, with only 20 million households, that's 34%, are enrolled in the National Social Registry. Government health spending is among the lowest globally. Nigeria spends less than peers despite higher need. The current landscape that we have right now, we have a rising poverty that I explained, that an additional 43 million people fell into poverty between 2018 to 2023, bringing it to a total of 123 million. Then the geographic disparities that the northern states hit hardest, but poverty is rising across all the regions. Then there's a financing gap that Nigerians' health spending ratio to public interest payments to health expenditure increased from 1.67 to 5.07 from 2010 to 2022. He also went further to explain that we had strategic opportunities for reform that can help transform these statistics that we have presently and improve the system that we're hoping to have. That's the demographic transition, that we have the world's youngest, largest working age population by 2050, and there's a need to invest in healthcare to leverage on that growing workforce. The fiscal transition, that's the 2023 swap compact between the federal and the state government, creates framework for coordinated health investments, and we need to tap into that opportunity. Then the National Social Registry integration, that the platform exists to target at least 50% of the vulnerable household. So we also need to use that opportunity to see how far we can reach to improve our healthcare, our health systems. The second presentation was from Mr. Mohammed Okore, that's from UNICEF, Social Policy Manager, and he talked about health insurance, a case for reaching the underserved children. The reality of the Southwest is that despite being economically stronger than the northern region, Southwest states show a concerning child health disparity. We have the highest in Lagos, Edo, Osun states, and the lowest in Ondo, Ogun, Oyo states. Under 5 mortality per 1,000 births is high in some of the states in the Southwest, and also low in Lagos and Osun states. He pushed that we should also say we should use health insurance as a social coverage that the the crisis that we're facing right now is that less than 5% of women and children have health insurance in the southwest states. Out-of-pocket spending expenditure exceeds 70% nationally. Oh, thank you. Some of the key recommendations that he proposed were target subsidies. We should use the state budget and the BHCPF to cover premiums for pregnant women, under 5 children, and poor households. Integrated financing, we should pool donor funds, state funds, and BHCPF funds for sustainability of the subsidized health insurance systems. Community mobilization, we need to leverage ward development committees for identification and enrollment on the register, on the National Security Register, Social Register rather. Comprehensive benefits, that we should ensure the full maternal and children coverage without user fees. Then we should also practice results-based purchasing. We should pay providers based on the quality and volume of the services that they perform. They also left us with a call to action that says health insurance will only work for the poor if we deliberately design it that way and ensure that no woman or child is left behind. So the key implications from both presentations made us understand that there's an urgent need for deliberate, equity-focused health insurance reform, that even though we have relative advantages, we cannot achieve optimal outcomes without addressing the premium affordability gap existing right now, and also covering the focusing on the less than 5% coverage crisis affecting children and women. The opportunities exist now with established infrastructure like the BHCPF, the state laws, the National Social Registry, to implement pro-poor targeting mechanisms that ensure that no woman or child is left behind in the journey towards universal health coverage. So this covers most of what we said yesterday, and the key point and the key deliberations that we've taken from the presentations that we will take back home to broaden, fleshing up. And then further down into our presentation today, we would also discuss the challenges that cut across the state's health insurance system. Thank you very much.
Thank you very much, Maiwa from Down Commission, just taking us on the activities of the day one of the conference. Thank you very much. Distinguished ladies and gentlemen, yesterday we had Dr. Olumide Okunla from World Bank. He took us on a presentation, and today we're going to have him again for another presentation titled Strategy for Connecting the Southwest Health Insurance Schemes. Ladies and gentlemen, I want to invite Dr. Olumide Okunla from World Bank for the presentation. Thank you.
So there's a lot of noise in that place where the computer is. So I don't know whether I'm meant to speak.
Hello, Bielu. Are you expecting me to speak?
Yes, sir. You can speak now.
Unfortunately, there's still that, there's an echo, but if you can hear me clearly, I just have one point to make. Kindly confirm that you can hear me.
We can hear you, sir.
Okay, so if, I don't know if the SOCU officer from Ondo State is in the room. I have also asked my colleagues In fact, he had to leave a meeting with the Minister of Finance to join this meeting. My colleague's name is Thomas Uba. He's a senior specialist under social protection. They are the ones managing the SOKU program, and I will ask him to introduce himself. I want him to just, in a few minutes, just talk about the state social registry from a high level. Then I can share with you my own thoughts on how this has major implication for health insurance mechanism. For instance, the people in the room who run health insurance programs will tell you that health insurance is about numbers. The larger a health insurance pool is, the more rewarding that program is, because you are able to reduce your risk, and your premiums then becomes much more accurate. That is the fundamental principle of health insurance. So being able to have one single pool will be perhaps one of the largest pools on the African continent. Sadly, Uba has gone now, but I wanted to make one quick point. In my presentation yesterday, you have the application or the number of people who are currently registered in each of the 5 or 6 Southwest states. And I don't know, if somebody can just quickly help me do some kind of calculation, just in 1 minute or so. If Ekiti has 650,000, or Ginodu, if you can help me quickly do this, 650,000 individuals. Lagos has 2.8 million individuals. Ogun has 860,000. Ondo has 800,000. Osun has 1,100. Oyo has, Osun has 1,100,000. Oyo has about 1 million as well. Ginodu, are you able to do that calculation? Just back of the envelope calculation.
That's 7.2 million people, sir.
7.2 million persons. Okay. So my point here is, if you have a 7 million health insurance pool, that is perhaps the most, that's even bigger than the current NHIA pool. But please let's hold on the health insurance pool first. Let my colleague, Uba, who manages this national program. By the way, the Nigerian National Social Registry is one of the largest in the world. Uba, you are welcome. Please, I don't know if you can introduce yourself. Thank you so much for joining this meeting. Just introduce yourself, and please, maybe if you want to just introduce colleagues to the National Social Registry. You don't have to make a presentation. So thank you so much. Go ahead, please.
Thank you, Dr. Olumide. Let me confirm you can hear me. I was having a bit of a challenge with technology. Can you hear me?
I can hear you online.
Okay, great. Good morning, everyone connected. Let me start by introducing myself. My name is Uba Thomas Uba. I work with the World Bank as a senior social protection specialist, and I'm the task team leader for the World Bank project that supports the federal government on the development of social registry delivery systems, particularly among them the social registry, digital payment systems, supporting the flagship cash transfer program of the federal government to provide shock response to households. I'm just going to follow on the introduction from Olumide to speak very briefly on the social registry, and I'm happy to take questions. First and foremost, the social registry at a conceptual level is a potential pool of beneficiaries for interventions. And these interventions span interventions in the social sector, health sector, education sector, etc. Specifically in Nigeria, this the social registry is being used by programs like the cash transfer, it's being used by private foundations like the Tony Elumelu Foundation, Dagote Foundation, and also other UN agencies, UN Women, etc. I think altogether about 13 agencies and firms have access to the social registry and are using it for their various interventions. At state level, it's being used by some state programs. Actually, for those states who know and are aware of the NG Cares program, the social registry is the foundation for the social cash transfers and livelihoods programs as well. So it has a good spread of usage in particular. How the social registry was built, in very simple terms, it was built from the ground up, which means we leveraged what we call community-based identification, where, to not bore you with too much detail, we basically had to interact with the community members, and the community members were in charge of selecting the individual and households who made it into the social registry. Because we started at a point where we were initially, prioritizing poor households to get into this registry, we were leveraging the expertise of community and the knowledge of community members to identify households who fit into this profile of poverty, after which an objective enumeration was done to capture the members of the household, to capture their economic and social characteristics, demographic. So there's a whole lot of information on the social registry at state level. The third thing I want to highlight is the social registry is, while a lot of the technical assistance and some of the funding comes from the federal level, the social registry is actually a state-based system. Every state has a state operations coordinating unit that sits in the Ministry of Budget and Economic Planning. In fact, the social registry started as a state-based intervention supported by the World Bank called YESO, before, just to ensure that there was uniformity and set standards, the Safety Nets project came on board, and that provided funding and technical assistance only to state teams to ensure that the social registry was implemented uniformly across all states. So it is actually a state-led endeavor, and even under NG Cares and other states have actually provided their own financing from state budget to ensure that the state registry is being expanded, state registry is being updated as well. In recent times, the registry, to answer the question of who is on the register, has partnered with NIMSI to incorporate the national identity number with the state social registry. And that will ease concerns of the uniqueness of the individuals in the registry, its ability to interact across databases and data sets. So that is one of the endeavors that is currently ongoing with the social registry. If you get to interact with the state operations coordinating units in various states, you see that they are busy revisiting households, doing household updates to ensure that the household data is at least fresh, and then collecting and registering for the national identity number for members in those households. So in terms of use cases beyond cash transfers and the other interventions I've mentioned, one of the things that we know the social registry has is a rich pool of household details. Right now, across the country, there are about 19 million households in the social registry. And that equates to about 80 million individuals, in the social registry. And just as I joined the call, Dr. Lubido was talking about a pool of about, is it 9 million or 7 million across some states in the Southwest. So that's the rich data we have. In terms of future plans for the social registry, we are now working with the government at federal and state level through the Ministry of Humanitarian Affairs, Budget and Planning, but also the state planning commissions or finance commissions to expand and update the registry through the NGCARES 2.0 and through the safety net project. What we want to see more and more of is, more states beyond Lagos, Kaduna, and a few others actually putting money. Nasarawa is also a very big investor in the social registry as well. So that's where, future, and the idea of that is we want to capture more and more people, both from rural, peri-urban, and urban centers into the social registry. So I've said a lot without any structured presentation, so it might get a bit confusing, but I'm going to be online to interact and answer a few questions that may come up. Dr. Mungwe, let me hand back over to you.
Thank you so much, Uba. Thank you so much. Let me just ask Biodun, that perhaps if there are questions on the operations of the social registry, what do people want to know? There may be, after Uba has left, we can then look at how that relates to bringing it together under health insurance. So first, because people say they don't trust that social registry, this is the person responsible nationally. And this is something our governments are using in other sectors. So what makes health different? So please, if there are questions for Uba, please, Biodo, I don't know if you can just help. I don't know how we can do it.
Yes, we state Soku official is here. I don't know if you want to speak.
Yes, thank you very much. Yes, thank you very much. My name is Bankole Oladua. I coordinate suffice to say that in the last 6 years, much has been achieved in the state.
Presently, in Ondo State, we have about 800,000 individual household members in our social register and about 260,000 household. And by household, we mean family. And just like my Oga has said there, we are presently doing our linking of the household that is already captured in the register to the NIN. This is the outcome of the position of the Presidential Task Force on social investment, which is to the effect that every, at least an individual within the household already captured in the SR must be linked to NIN. And this is for me to humanize the register, not just to make it a figure, so that something that we can actually relate with. And that's, as I've been said earlier on, that is what is currently going on in the state now. And as of today now, we have linked about 113,000 individuals to the NIN, which in a way can now make it very, very easier to actually identify those that are benefiting from the social register, social investment, one way or the other. And I want to also say that this approach of having the single register is something that has been entirely contracted to the community. That is, it is the community member themselves that actually identify those that are poor and vulnerable among them, upon which the enumerators will now collect their vital statistics. And with that, we will now do our own level of cleaning before we even send to Abuja, which you call it NASCO, which you call it look at it to ensure that we have a data that is very, very okay. And so, like it has been said, we have been having support from the federal government since the inception. Actually, in those states started with YESO, Youth Employment and Social Support Operation, and essentially the mandate is to establish the single register of poor and vulnerable households. And having been doing this, we are not just satisfied with having the register of poor and vulnerable households. We are equally interested in level of support, how we can mitigate the poverty so that we can reduce the level of poverty in our state. And we have enjoyed support from Tony Elumelu Foundation. We have enjoyed support from the federal government cash transfer. In fact, as we speak, about few weeks ago now, there is this Renewing Hope cash transfer, which is about 75,000 naira, and those that are beneficiary are people that are captured in our SR. So a lot of support. In fact, at the beginning, we equally have collaboration with the National Directorate of Employment, at which about 600 youth were mined from the register and they were accommodated at the Federal College of Agriculture here in Akure, where they were trained on 10 different skill sets so that they can be employer of labor, not just to be looking for job. Because we have identified that the major reason for poverty is lack of access to employment opportunity. And for us to be able to actually attack poverty frontally, there is every need to ensure that people are gainfully employed. And I also use opportunity at every forum to actually talk to our parents, to advise our parents. For instance, some people in this country, you believe that if you are a graduate, you cannot use your hand. I think that's a wrong mentality. So we need to encourage our youth to be able to use their hand. Now, in the part of the country that I come from, there's this analogy that meaning that if you are work for anybody, whether government or private organization, you can never be wealthy.
Okay, so Abiodun. So perhaps it's important, I would like maybe participants in the hall having Uba in the room and the Soku focal officer from Ondo State. Let us know what are the challenges state insurance entities have with the social registry. It will be useful before Uba leaves if we can interrogate some of the responses you said you got yesterday in terms of what are the problems or challenges. Why can we not adapt that? Back to you.
Yeah, Dr. Okwala, this is Dr. Oyene, DG Ondo State Contributory Health Commission. Thank you so much for your presentation yesterday. I really appreciate you. We learned a lot. The SOCO coordinator is seated by my side here, and we invited him for this purpose so that we can address some of these issues that people have raised. When we started the BHCPF in 2021, we collaborated. We mined the list of our beneficiaries from the social register from the state. But we identified some of the challenges which are being addressed, and I still believe it's work in progress, that people are highly migrant. So when we mined, and by the time we got to the field to enroll them to do physical verification, we discovered that quite a number of them no longer reside in the address that was identified. And one of the things that he has proceeded to address those issues is to do regular validation and updating of the register, which I confirm that they do annually, but if funds are available, I believe it should be biannual. People move a lot. People are laborers. People migrate from one ward to another. So if the BACPF is premised on the fact that we should have one PHC per ward, and people have migrated to another ward, then you will not find them there. And utilization will be extremely low. And I think that is being addressed, and we hope with more funding, they can do biannual verification and validation of that register. I also confirm that they also need to have a contact center where they can do continuous verification by phone. Of course, not all of them may be able to be reached by phone. I'm also glad that they are now equipped to also issue NIN. We are also equipped, and we're also ensuring that all our beneficiaries across all our schemes have national identification number, and in areas that are hard to reach or maybe there are no presence of people to issue them, then our team will go there and issue it to them. Secondly, one of the clusters of people to be enrolled under the BHCPF are pregnant women. But this is not a permanent state. So if somebody is pregnant 7 months, in 2 months the person will deliver. So is no longer a pregnant woman. So those are basic things that we also need to look at the dynamics of what do we need to do, because it cannot be a perpetual state that pregnancy is a perpetual state. Somebody cannot be pregnant forever. So by the time he's no longer pregnant, we also need to have a way of coordinating this data to ensure that we move that person from a pregnant woman to, it could be poor and vulnerable or women of reproductive age group. Then we also talk about children under 5. It's also not a permanent state. Somebody is 4 years, 8 months. In 3 months' time, or 4 months' time, or 5 months' time, the person is no longer under 5. So that's why there is a reason for us to have regular update of this register. And by so doing, I can still assure you that we still mine from the social register. But if you look at the data that he mentioned, if you have 260,000 households, and from the calculation yesterday, maybe average of maybe 3 to 4 people per household, we are talking about close to 500,000. From the disbursement of the BHCPF currently, we can only accommodate about 30,000 in the state. So that's still a far gap from the total number of poor and vulnerable people that are in the state. I would like to stop here to see that we are making progress in the state. We are willing to make use of the social register as long as it addresses some of these issues that we have raised. And we are not jettisoning the opportunity to collaborate with the SOCU office, to collaborate with the initiative of National Health Insurance Agency, and also the World Bank. So the state is making progress, and he has confirmed to me that that register is being worked on, and we always work with them through the office of the program manager for the BHCPF. We mine from it, but we still need more work to be done, and also we need more funds to be able to cater for the total number of people that are actually poor and vulnerable. Thank you so much. I appreciate it.
Would you want me to respond now?
Hold on,
or
sir.
the
Let
other-
Lagos State. Lagos want to make contributions, sir.
Thank you. Doc, this is Rotimi from Lagos. I think that the issue with the SOCO register, I was part of vulnerable coverage directly for the first 3 years in the twilight period of Lashma. And the issue with the SOCO register was validity and integrity of data. But I tell you now that it appears as if there's confidence now in the data over time. So imagine going through Ondo State data, just an example. Number 1, 2, 3, 4, 5, and randomly you get to number 67, and you find Dr. Olusegun Mimeko's name in the SOCO register. These were the replicas of the experiences we had at the twilight stage. We found names of prominent and known people in the register. So we were thinking back, was it that community leaders that were politically inclined were putting names of people that were really not vulnerable, and you know? But in Lagos, we targeted slum areas, Makoko for instance, within the community, where you have the poor, the poorest of the poor, and we deployed the World Bank assisted means testing software. Of course, with tested algorithm, we were able to profile who was poor, who was very poor, and who was far, far below the ladder. So what Lagos did in terms of putting confidence back in the list was that we didn't do an annual revalidation or bi-monthly. We put people on ground called IFOs in all those communities. They live there. And what they do on daily basis is to do revalidation on daily basis as an alternate and complement data by Lashma beside the SOCO list in Lagos. Thank you.
You may want to respond, sir.
Thank you very much. I just want to ask, Uba, do you want me to go first? to discuss the SOCU comments, and I then come in on the health insurance aspect of it. Is that okay?
That's fine with me.
So go ahead.
Okay. So first, I think let me thank the two speakers from Lagos and I believe Ondo on raising their concerns. And I'm actually very happy to hear that there is collaboration between parties, and there's willingness to work with the the social register. And I'm glad to hear that at least there is renewed confidence in the approach going. So I think our colleague from Ondo actually raised the concerns and actually posed the solutions, which I'm just going to emphasize that we are supporting, but encouraging the states to take up the challenge to do more and put in more. So on the issue of financing, and we can speak more about the NGKS program that is now, a program for results focused on largely on the expansion and updates of the social register. That is, funding coming directly from the state budget to the social register. And the SOCUs are now, what we call a delivery platform under the state for that program. So at least there'll be a bit more funding, for the social register at state level. One of the things that, two things that we will encourage in terms of direction of travel for the social register at state level is that one, the social register needs to be a bit more dynamic. So we need to get to a point where it's a dynamic register. And secondly, that can only happen if there is available infrastructure, so like the contact center that was mentioned. So the SOCU serves as the foundation, but these contact centers need to be a bit more available to places where, not just at local government headquarters, but within communities or wards, at the very least, to ensure that people can come there and update their household information dynamically. That will involve some financing for infrastructure and also for personnel as well. The last thing I want to address is on the issue of tracking the status, so for dynamic status on migrating populations. So for migrating populations, a dynamic social register helps that. And this is where I think the mean integration is important, because then you can actually track who moves from where to where using an ID, that is foundational, biometrically backed, and actually helps us keep track of unique individuals. So as they are updating their information when they move from ward to ward or local government to local government, then we can ensure that at the very least you have data that is most updated. But also on things like making the data a bit more smart. If you record a 7-month-old pregnancy today, you want the data to be able to tell you that in 2 months, either this pregnancy has been delivered, without even necessarily being an update. These are things that the data can be intuitive about. When we started the social register, they initially were only collecting age, which meant that the date was, the age was static. But over time, we modified the data and started collecting date of birth. So that way we can actually keep track of people's ages. So that if you visit the household and somebody is 5 today, you know that the next time you look at the data, because you have the date of birth, you are able to say that, okay, this person is no longer 5 in 2 years' time. They are now, 7 years old. I do like the idea of, having parallel structures to work with the SOCU. And I think that is a brilliant idea that Lagos is doing. But I would really request and encourage that that data can be fed back into the social registry to make it more robust. The last thing I would say in terms of direction of travel is that the expansion of the social register right now is being done in such a way that any and everyone, should be there. So we started at poor and vulnerable, but the idea is, we need to increase the coverage to cover as many, families and households as possible. And the reason is very simple. During COVID, and when the lockdown happened, the people who were largely affected were not necessarily people who were termed poor and vulnerable by their existing communities. But these are people that, because of the lockdown, their daily livelihoods were taken away, and they suddenly became, the vulnerable in the community. And they were the ones that really needed, whatever support that needed to come. Also, in the case of like the Borno floods or other floods that happen, a lot of times those floods, flash floods, happen in urban centers or peri-urban centers that are not necessarily poor and vulnerable at the time, but the moment that shock, hits, then there is need for support. So capturing all these people in the social registry make it easy for planning for items of, in terms of shock response or adaptive support to households. So at that point in time, if every household is in the social registry and is updated regularly, we wouldn't have concerns that the president's name, or a prominent politician is involved, because then everybody is going to be in the register. It's going to be an issue of now structuring the interventions to ensure that the interventions get to the right people of whose data is collected. So let me stop there and hand over back to Dr.
Thank you, Uba. Dr. Ini, always a pleasure to hear from you and Rotimi. And I can say that this is a very serious meeting. All the big people are in the room. A couple of points. Let me start with a foundational point, which everybody in the room understands, but I will just repeat it. First, all these shares are based or were established on the foundation of universal health coverage. The principle and commitment to universal health coverage means that every single person is entitled. That is UHC when we say UHC. There's also one other important thing we know about UHC. Without public financing, no state, no country can achieve UHC, which is now why we went into the status of public financing revenues yesterday in my presentation. But we also found out that money is tight, so we cannot cover 100%. We have to prioritize. That is now why we're doing all that we're doing and having this kind of conversation. But let me give one example before I answer those questions. India did not bother about whether the money was available or not. India launched the world's largest health insurance program, the PMJ. Please find out. And say, you know what? If you are sick, come into the program. When at that point of encounter, I give you a card. And that's how India, and they launched that program in under 6 weeks, the world's largest health insurance program, social health insurance program, the PMJ. So, which means that sometimes when we overthink this thing, and the counterpoint to that is that let's look at the rate of enrollment of all of these shares and look at it to say, at the rate we are going, can we achieve universal health coverage? It's probably very unlikely. That rate is too slow. If the trajectory, if we say human capital is the backbone of our human capital, is our backbone of our economic competitiveness. And the slower we are, the more problem we will get into. So just foundational things. Now, to address some of the key questions here. If you look at the social registry, it's split into 10 deciles. And I don't know if Biodun, in fact, it's in slide 37 of what I presented yesterday. So, which meant that the reason for that disaggregation, let's even assume that it is bad, there are problems with it. The opportunity that disaggregation does is you can start with the poorest, who don't really even have anything, from decile 1, which is the poorest of the poor, and begin to titrate upwards to say, okay, look, by the time I do decile 1, I've covered 100% of the poorest. I move on to decile 2, and you begin to go on and on like that. So within that registry, there's an opportunity to further prioritize, which is really why, in the absence of universality, we can begin to prioritize income groups. Number 2 is that this only, yes, this slide. And what this does for us is it helps our advocacy efforts, because I can then say, look, Mr. Governor, this is the disaggregation of my state, the entire state. Sir, you can bring the history book and do 100% of this. Otherwise, we can go all the way to decile 6, decile 7. If we put some of the money from BHCPF to it can even push us to decile 8, decile 9. That to me is the strongest instrument here. The next point to make is that, honestly speaking, nowhere in the world does the state health insurance or does a public health insurance entity does enrollment. The enrollment increases your transaction cost. It's not our role, but we were doing it at the time because there was nothing available. Now that it's available, outsource it. Just take it out and focus on the purchasing element. That is really the core of our health insurance duty. But the more we spend time, right now, if you look at the work health insurance entities are doing across Nigeria today, 50% of our work actually has to do with enrollment and registration. And that takes away time that we should be doing core health insurance, empanel providers, work on the quality, provider payment. That is the real core. I mean, I've known Dr. Odehi for a long time when he was in the private sector. Those are the kind of things that we used to do. And I'm sure I would like you to even say, look, now, what do I spend my time doing? When you are in the private sector and now in the public sector, when you have to now be looking at this kind of things, that's what we should be doing. The other points to make is that the so what of all of this, unfortunately, I can't share my slides, but is I asked my colleague, Dr. Jinodu, to add up all of the households in the Southwest region. Add it all up. Kito, I'll ask you to speak now. Maybe about 7 million or 8 million individuals. I don't know the number in households. And I present it to the Odua State governors. I said, sir, if we want to achieve 100% universal health coverage, which we achieved in the Western region in 1959, this is what it will cost. Can we all contribute money and do it? 100% UHC, taking us back to 1960, when the Southwest region had universal health coverage. This is how much it will cost. Because now we have a number, now we have a data set we can trust, and then it becomes a matter of policy advocacy with evidence. To me, I think that's where we should be headed for, and I'm happy to hear some of the technical things happening in terms of NIN and all of that. Yes, the last point is to say, look, yes, under 5, pregnancy. These are entry points for you into the system. Yes, they come in, but then you register them so that they then be on the platform. But we shouldn't really be discussing this. To me, let's go big so that we can have a much more profitable business. The larger we are, the more profitable and sustainable this program is. And if we are able to interconnect digitally, then it means that dynamism we are talking about, that means you are portable, you can have your insurance portability. What Dawn Commission is saying here, this is something that a number of states in the United States are already doing. Coming together, have a much more profitable, sustainable health insurance program, and have state portability. This, to me, I believe, is what the Southwest Development Commission might want to do. And, Beodo, I don't know if you know this. The BATPF comes from 1% of the CRF, which is what Dr. Ini says can only do 30,000. The Southwest Development Commission and other regional commissions are also getting a certain percentage of CRF. So that means the 30,000 you're mentioning, if we are able to come up with a good communique here, you can also then begin to look at how we can achieve 100% coverage in our different geopolitical zones. Thank you so much. Kito, do you have a number? What's the total number of households in the Southwest? And if you do a scenario of maybe 40,000 per household, how much will it cost? Just to humor ourselves.
So the total number of enumerated households by the available record on the NASCO website, enumerated in the Southwest, is about 850,000 households. However, this has exactly. That has been significantly skewed by the numbers from Lagos. And without the numbers from Lagos, it's about 380,000 households.
If you do a premium of 40,000 per household, how much would that be?
So if we do a premium of 40,000 per household, when we exclude Lagos, we're looking at about 15.1 billion per annum. And when we include Lagos, that number goes to about 32 billion per annum.
So, Building, let me end my case here. Tell me, all the governors of the Southwest, can they not put 30 billion naira down per annum? It can happen next week. Don't let's underchange or shortchange ourselves. We can raise 30 billion. Now state governments, and that's why I showed the slide yesterday, state governments are now making 3 times revenue. If you look at the slide I showed yesterday, if you go to slide, I'm sorry, please. Oh God, I can't find it. If you go to slide 23, no, sorry, not slide 23, sorry, slide 29, slide 29. This is the slide from last year, early this year. We have the latest figures. States are now collecting 3 times the revenue. And with the calculation that Kiton has done now, the Southwest can put 30 billion down, and then we have achieved universal health coverage. We need to have big ambitions. Thank you so much. I thank you for the opportunity. But if you can really show that slide 29, it tells you how much state governments are now earning, based on what the benefits from the new subsidy removal regime. Thank you so much. I'm back to you.
Thank you so much. We appreciate your contribution. Okay. No, he has, that's what he wants to say.
Hello?
Yes. Hello, sir. I said thank you so much. We appreciate, are you? Thank you so much, sir. We appreciate your contribution. I just want Mr. Uba has left the link. I just wanted to ask, from this, all these social investments, can they also propose to the federal government that all this money being disbursed, they can also use part of it for health insurance? Is there a possibility for that, sir?
Okay, so there are two parts, like the SOCU person will tell you. The social register is a register. So people will then come and say, this is your register, I want you to use it in water sector, agri sector. So people come to ask for it. Believe you me, it is only the health sector that has said they are not recognizing it. So you can't even make the link, and that is one of my personal frustration in this space. So look, they're just having a meeting this morning for the cash transfer. So because health is not even in the room, not in the room because they said they don't recognize it. But that's a different discussion. We need to recognize it first. So at the national level, if I have 80 million Nigerians that I know, and I then say, Mr. President, can you pay the premium for these 80 million people? Or let's divide it, which is now what we're doing at a regional scale. That is the conversation we are having now. If the governors of the Southwest will say, look, that's your cash transfer, I'm going to put 15 billion down. Half of it, use it to do the health insurance premium. That's the way it works. Back to you, sir.
All right, thank you, sir. Please hold on, sir. There's a comment from the representative of the governor of Ondo State.
Well, thank you very much. I've listened to your discussions, and I know that you have really done a lot to be sure we can get a progressive and proper register. Professor Michael Simidele Odimayo, the Special Advisor on Health to the Governor of Ondo State, actually representing Mr. Governor in this program. Now, I just want to say one or two things because a lot has been said. Number one, we have already talked about the social register and the importance of regular update, which has been well alluded to. And we have talked about linking it to NIN, which is a very good one. But I also want to suggest, is there a possibility of it having an auto update, that you program it in such a way that it can auto update itself? It's basically about programming it so that it can be able to auto update itself. Then another thing is, most of this conditional cash transfer that is done, I'm sure you do it to an account. And so can we now also be able to look at the possibility of assessing the BVN of the people that are involved, so that you can also be able to assess them as their condition gets better? You cannot continue to classify them under the poorest of the poor, because those support that is given to them, they are also meant to be able to enhance them and get them to get out of that poverty line so that the system can be better. Because any of them can continue to enjoy the free gift and then not be committed to improving their own lives. But I'm sure this program is not meant to continue to keep the people in perpetuity of poverty, but rather to enhance them to be able to get out of that. You have mentioned about the state component, which, well, I feel that we really need to encourage the state governors to be able to put in their component more. But as also somebody has said, that part of this conditional cash transfer, can we not actually get it done so that it will go directly into the basic program, basic care provision fund in the insurance system? Maybe a percentage of that can be able to get into it, and that will have just guaranteed that they are automatically registered, and if they need health concern, they can be able to get in. Then finally, what I want to say with respect to the fact that every other person or every other group of team, they are using the register, the social register, but you think that health is not accepting it, the health sector. I want to just make an explanation to that, that rather than thinking in that direction, you should also look at it that it's as if it is the health that is using it more, that is struggling to rely on it. That is why they are able to pick some flaws in it, and then they are giving you feedback so that you can make it better, so that they can be able to better rely on it. And I think that is the direction I look at it, because the document or the information you are giving unto them, they are going to the field to check. Sometimes they check some of those people, they discover, they have already left here to Kano. Some people say, oh, they have traveled here back to Lagos. Or someone say he has moved from here, and he gets there, you say the person is pregnant, he gets there, he is already having a child that is already 1 year old. So they are able, because they are using your data, they are able to give you feedback. And I think you should appreciate them more for that and partner better with them, so that you can have a much better data that can be able to enhance our system. I want to appreciate you for all that you have done and that you have been doing, because it's obvious that you have been doing a lot and you are making effort to be better, and I think it shall really result in a better nation. Thank you very much.
Dr. Olumide, I don't know if you have something to say before we bring something.
I agree. I agree with every single statement made by Professor. 1,000%. I only have one comment, which is really not related to the comments. The comments are straightforward. I appreciate and I agree. I looked at my data set now. Ondo State has about 240,000 households. Professor, and I will just my question to you is this, because I know your governor, I know Governor Lucky pretty well. I know your name very well. And I just want to give you a challenge, Professor. I did a calculation. I multiplied 250,000 households by 40,000. That is equivalent to 10 billion naira per annum. Professor, you will make history. Governor Lucky will make history if he signs off a check of 10 billion, hands it over to Oyeniyi, and then and then we know that under this administration, Ondo State has achieved universal health coverage, becoming the first state to achieve universal health coverage. I am saying it is possible. That is the only message I come here with. So that instead of us arguing and all of that, so that by the time of service coverage, when that person comes to take service, I am able to then discern, oh, you are pregnant now, you are not pregnant, you were under 5 when you are, That is really where we now, and that takes to your last point about, yes, at the point of service, I am then able to let you know your condition at the time. However, what brings everybody into that pool is the 10 billion naira, which I don't know the Ondo Soku person, whether it has replaced more than 250,000 households now, but tomorrow morning, sir, Professor, Ondo State can be the first state in Nigeria to launch a universal health coverage where it can then say, all my citizens are covered under health insurance, because I know you have the money. Professor, is this a challenge you would like to take? You have one of the best CEOs of the state insurance entities in that room. He worked in the private sector for 10 years before joining the program. Please take my challenge. Abiodun, I hope this is something we can take.
Yeah, thank you so much, sir. I appreciate it, sir. Thank you. We'll talk later, sir. Thank you so much. We have, in regards to to your team members, sir. Thanks. All right, I think we're done with that session. A round of applause for Dr. Olumide and every contributors too, So the session we're going, because today we have half a day today. So the session we are going next into is to try to collectively profile solutions to some of the challenges that were presented yesterday. And in order for us to have a very organized session, we will break us into groups. We have about six challenges that resonate across the 6 states. So we'll have 6 groups. Each group will deal with a challenge, and then maybe in 1 hour we'll come back and we'll nominate somebody to come and present some of the recommendations to those challenges so that we can take it forward. But I want to crave the indulgence of the head of agencies to please, they will stay in one of the tables and others will join them on the table. But please don't stay with your head of agency. Look for another state to stay with. You have always been together. At least let's go to another state to also brainstorm with them. So please, okay, Dr. Dosumi is already here. Let me leave him there. Please, sir, you can come to this table, sir. Oh, sorry, Doctor is already here too. Maybe you should come to this table, sir. I'm sorry, or you are not the last, but please just let us others just join them. But please don't stay with your colleagues from your state. Just go to any state of your choice, but please don't stay with your colleagues in your state. Thank you. Please, please, sir. I'm sorry. Please, can you just let Oyo? But you can stay with Oyo if you are not Oyo from your state. You can stay with Oyo there, sir. Thank you. So can we just do that in 1 hour? And we can also make it a working tea break, so each table can go and just take their tea and put it on the table as they work. I say you can stay on the table. Sir, you can stay if you want to stay. Oh, okay, sir. All right, sir. All right, thank you, sir.
Thank you very much. I will be going now. I hope to get back or get final brief from Dr. Yenenye on how things are. I want to appreciate you, and I really see a lot of commitment in the health sector and in the health insurance system. I thought it's only our state that is doing the topmost, but I can see a lot of people are trying to catch up with us. So, so that is a very good one. Ondo State is actually giving a lot to the basic healthcare. I don't just want to respond to him because it will keep the discussion longer, but I need us to know, at present we have about 82,000 enrollees in the basic healthcare system. That is talking about the poorest of the poor, and we are working to get more. As we talk now, virtually we are working actively, all the sickle cell warriors or patients, we are getting them to all be within that, because we know those type of disease can actually push a family below the poverty line. But once those crises, even as we educate people on right choice in marriage, but we are still trying to sort out those things. And we quite understand that caring and making sure that this health insurance is successful is central to removing poverty from the land. Because there is no way, if we make ourselves to be committed to the healthcare, all the people that were saying they are poorest of the poorest, before we know, they will move out of that poverty line. Because health is a major component of disease and of wealth. And as long as there are diseases and that is plaguing an individual, that person can hardly get out of the poverty line. So I want to encourage us that what we are doing fantastically, but we can go further. Just from the theme that we had, we have gone far, but we still have a long way to go. Let's keep up the effort, and I'm sure we can really do a lot to improve our system. Thank you very much.
Thanks, sir. Thanks, sir. Regards to His Excellency, sir. We appreciate your coming. Thank you. Please, Marwa, please, can you put just do it like that, 1, 2, 3, 4, 5, 6. Okay, and give me the one you have. Sorry, sir. Please, can you project? Yeah. Sorry, I'm not sure you can see my words. Sorry, can you leave Dr. Elio? Can you leave Dr. Elio? Sorry, let's manage this one. Oh, Lagos, Ekiti and Lagos cannot be. You are the one from Ekiti. Sorry, sir. 1, 2, 3, 4. Oh, 5 people. Okay, you can share somebody can share, but another question, please. I'll put another question. So, Lagos. Yes. Are you Lagos, man? Yeah, you need to move. Are you Ondo? Lagos, please. You can join or you're here. Sorry, are you Ondo, sir? Eh? ONHI, Hey, but you can still join them. You can benefit from your wealth of experience. Or you want to join Oyo? Sorry, sir, are you? Ma? Eh? And you too, so you can, sir. Oh, maybe you can join. Come forward. You can join Lagos, please. No, he's not. He's Lagos, so he can join Ekiti. He can join Ekiti, but he can join Lagos. That's all. You want to? I think. Sorry. What do you have? What question is that? Hello. Sorry. What question is that? Question one for table one. Question two for table two. I didn't. I gave you question three, sir. Did I give you question three? Three. I've not given you anyone. Did I give you anyone? No, you cannot. Ekiti will get his question. So Ekiti should do 4, please. Ekiti 4. Oyo will do 5. 5. They will project it. Nobody is joining Doctor here. Auntie, Shebi, you are Lagos. Please join Ondo. Please join Ondo. No, you already have him. Auntie, please join them. Join Ondo, please. Okay. But you will join Ekiti. And then you should join Ekiti, please. I said number 4, Abi. Oh yeah, I'll bring. I said number 5, Abi. Please, sir, can you do number 5? They say there are challenges, and just give us idea of how those challenges can be mitigated. Eh? Yes, to those challenges. So Ondo will do 6, number 6. No. Sorry, are you from which state? Oyo. Oyo can join Ocean. Please join Ocean. Sorry, what state are you from? Oyo, okay, join Ondo. Please join Ondo, please. Yeah, Ondo, yeah. And Tutu, no, yeah, but Tutu. Sir, Mr. Doctor, your name? Ondo, Ogun will join. So we can do a walking tea break. So, but Oyo will have the privilege of going first. We just go table by table so that we don't distract ourselves. Oyo, when Oyo is ready, you can just go first. Then follow. Yes. Let Oyo. When Oyo is ready, Oyo will go. Then follow by Ekiti, Lagos, then Ondo, then Oyo, and finally Ogun. Thank you. So we'll just do this for 1 hour so that you can just leave after now. please, let's get someone to write out some of those recommendations because we are going to read it out here for everybody to hear. It's not for Don Commission alone. It's for everybody. Please, let's get something to, let's have a secretary that will write it so that the person, you nominate someone to come and present it to, you know, whatever you come up with. Thank you.
All right, so these are some of the things we discussed and the pointers to which we're able to put together as preferred solutions to this problem. The first one, which is the low overall coverage, I want us to see it from this perspective that until those persons at the grassroots own health insurance, it will be difficult for us to penetrate. Because number one, we are not giving it to them for free. They have to pay a token. And since that's the case, we have to look for a way to make them own it. So we are able to say that we should create awareness. And we spoke about social media. Some of the grassroots, they are not on social media, but we still won't take that part away. We spoke about discussing with faith-based organizations, for instance, churches, the mosques, and what have you, the Asalatu bodies and the likes. So we spoke about traditional leaders too. Most times in a particular community, the traditional leader will say, oh, this is what we are doing, and they will follow lead. Like they'll take the lead, others would follow. Number two, for still coverage and access gap, we spoke about enforcement of already existing policies. We know that there's a policy in place that health insurance is mandatory for all, but now the enforcement is very weak. So how do we do this? We're able to come up with this. We said for businesses to operate in a particular environment, he or she must provide an evidence of insurance. So for you to complete your course registration for an institution, you must provide your health insurance. We can all recall when JAMB was, when they mandated NIN for anybody that wants to enroll for JAMB, be you a minor, be you an adult, you must provide NIN. So we can still go through that route. For the basic transporter out there that wants to operate in that state, must provide certificate of health insurance. You want to renew your license, anything that is being regulated by the state, you must provide certificate of health insurance. And we also spoke about the activation of the equity funding. On paper, it's written that there's an equity fund, but I can say categorically some states are not enjoying this equity funding. The other aspect, which is the rural access barrier. Yes, rural access barrier. We noticed, or we discussed at length, that how do those persons in the rural area have access to these things that we are preaching, health insurance here, insurance there. Sometimes we have public facilities there. Fine, Oyo State government, for example, have done its own bit by renovating the PHCs across board, but it still gets there, nobody's accessing, it's just there. So what do we do? So since sometimes the government might not, probably their policies and the likes, might not actually make that PHCs functional, why not to engage private facilities too, to boost health insurance coverage? For instance, in a particular community, when I know we have some petty, very little private hospitals, we can engage them and tell them to be part of this by letting them know. Because one of the things about health insurance is you must own it. You must own it. See it as your own before you can actually have one or two things to get from it. Now, renovation of dilapidated structures too. It's one of the things we can actually do for these rural access barriers to be defeated. We should engage more of the community-based workers. For instance, you're in a community where, okay, we did something recently in Oyo State. Sorry, I'll be using Oyo for example. We wanted to actually penetrate them for some free health insurance. We had to engage those persons in that locality. They understand their people better. They know how to relate with them, and they know how to bring them on board. So they were able to help us with that. So if we can still encourage these persons, train them, like those persons in that community, train them for that purpose, they would be able to help us achieve this. Geographical inequality, that's difficulty reaching underserved communities. Now, basically that's a government issue. For instance, there's a place we traveled to, I can't forget. We got there like this. There was no way for cars to go in again. So the only thing that can go in is just a bike. Now, from the place they dropped us to the nearest village we are going to is about 2 hours, 30 minutes drive on a bike. And the roads are very bad. Sometimes you have poor network or no network at all. What do? I feel if government can come in, probably in that community, give them a standard PHC, make sure they have access to good roads, which will actually help these health insurance that we are preaching about. And so we still notice that there is the issue of insecurity. We shouldn't take that out of the picture too. It's very, very important. There was a place we got to. It was when we got to that junction. The person leading us said, oh, you came Dani now. I like her. So we had to now go back and re-strategize. So normally we are supposed to talk about this. There are some communities that are prone to insecurity. Because of that, it's stopping this mission we are preaching, which is health insurance here and there. So if we can still work on that, we provide a solution that in a particular community, they do local vigilante groups, they are there. So why don't you engage them for every of your meetings in that environment? They will help you push, they will help us push this forward. Then basically that, the last part here says reaching the unreachable, that's breaking distance barriers to serve the remote populations. We painted an example. For instance, we want to vote. 2027 is on the way, right? Whether you like it or not, those places you are saying is so distant, ballot box will get there. Election will see happen there. So we feel that if the government want to get this into work, it will work. So the same way they're able to push ballot box to those areas, push health insurance to them. For instance, make it available. Like if it's road there's a problem, create the road. If they don't have facilities, do it. And we noticed that, for instance, in Oyo State, 33 local governments, we have PHCs across board, but it's not evenly distributed. For instance, let me use the example, Kajula local government. If you give Kajula, for example, 5 primary healthcare centers, communities under Kajula is more than the 5 PHCs. How do we do it? We said, would accredit more facilities so it would help us with coverage. Thank you very much for the time.
Thank you very much, Group 1. Please help me give the Secretariat your write-up. We need it. Okay, so Group 2, please, the representative for Group 2. So, please, round of applause for them. Thank you very much, sir.
Thank you very much. Our own topic is financial and economic pressure. The first one is premium affordability, rising inflation affecting both. Well, we have suggested that there should be formal sector activation in all states. When you have this, it's a source of regular income for that state health insurance agency. For the informal sector, one, you have to create awareness. Let people know the benefits of health insurance. There must be continuous provision because, for instance, Osun has 12,066 naira as premium for a whole year. Ondo has 18,000. Ogun has 18,000. Now tell them to pay 1,500 naira every month. Tell them to pay 1,500 naira every month, and you will see that it will be easier for them. In fact, there was one company that approached me recently that said they want to develop an application for us where people can be paying money. They will form a wallet that, okay, you went to market this today, and when you came back, you are able to afford 200 naira. Put it in that wallet. Tomorrow it is 500 naira. Put it in that wallet. Once that wallet has grown to 12,066 naira, the wallet is linked to our own account. It will automatically move the money to our account and generate a message to you that you have paid for health insurance for a year and your card will be ready in 48 hours. As the person is still doing it, the money is still accumulating in that wallet. After some time, when it gets to that, it moves it, unless it has not reached 1 year, where there will be renewal. But after 1 year, it automatically moves it and guarantees that the person continue to have the money available for healthcare. What some people spend on data and recharge card every month is far, far more than 1,000 or 1,500. But they need the correct orientation to know that health is more important than that what they spend the money on. Then irregular funding, delayed BACPF disbursements from federal government, and some other things. Well, I think we have NHIA people here, because that BACPF thing has become, so I don't know what we have to do. They say we are moving from 1.0 to 2.0. The last quarter of last year of 1.0 has not been paid. Now this is the second quarter ending of 2.0 that has not been paid. Maybe we should have a way of rectifying this. And I know there are quite a lot of money in the Federal Ministry of Health for this purpose, but they may be able to tell us. But funding also, we should have a good rapport with our Ministry of Finance. I say something in Osun State that priority, the most priority in Osun is the worker's salary. After that, the insurance, the OEs, something comes in. And you just need to have very good rapport with the Ministry of Finance, with the Accountant General, with the Commissioner for Finance, and everybody that has to do with payment. Otherwise, you will be running etasketa. And this is not a matter of file. Sometimes, in fact, one day when I was in the universities at that time, I went to Lagos and somebody took me to Ikoyi Club. And I was surprised the type of personalities I met there. And I now saw it that, you see, they control Nigeria, not from Abuja, from those centers. That's where they control Nigeria. So sometimes you may need to control your finances through some means like that. It is not file. There are some other clubs too. Maybe those ones I will take you there. So you must have very good interaction with the whole monies, with those who hold the money. Funding constraints, challenges in sustaining equity grants for vulnerable populations. During our table discussion, that you see, this world, most times nothing goes for nothing. Rub my back, I rub your back. You have to, within your state, look at things you can do to promote the government. Once you are promoting the government will also look back at you and assist you. I told you quite a lot of things we have done in Osun State. Before we were not getting the equity, it was the governor himself that said, I said 2% of the CRF. I said, okay, we will start first with 1% of the CRF. And this month, I got the 1%. And it's going to be a constant thing every month, because we have also done something to promote the government. Limited political will. By fire, by force, you have to find a way to be politically relevant. I told somebody that, yes, I started my residency in ophthalmology. But after some time, I left to ONG to become a gynecologist. When I was doing ophthalmology, in fact, there was one day, two things sent me off. We didn't have operating microscope that time. So I operated a patient with corneal laceration. I finished the repair in 15 minutes, but the needle got lost inside the eye. And it was very, very tiny needle. So I was looking for the needle everywhere until something came to my mind that I could use magnet. So I got magnet, put it in surgical glove, put it in the hair, and the needle was attracted to the magnet. Then one day, I said, and that was after 2 hours of looking for the needle. One day I met a man, and he said, Dr. Akindele, you don't remember me again? He said, I can't remember you. Are putting on dark glasses. So he remembered, he removed it and said, "You removed this my eye." And I said, "That's not a good thing to to be remembered for." So I left ophthalmology to ONG. And I was like, "Ojú náà méjèèjì, mo kúrò lójú ayé, mo bọ́ sójú ara, ojú náà méjèèjì." But you see, after becoming ES, mo rí pé ojú ara lásán ò ní dá. I have to go back to ojú ayé. So you have to be seen. Yes, not that I went to ophthalmology. You have to be seen everywhere. If the governor is going to bath, unless he restrain you, you have to be seen there. Anywhere he is going, you have to, even if it's not comfortable. I was resting at home one day because I had malaria. And they said the governor was doing one empowerment. They must see you. You're not going to ophthalmology cage. So you have to develop that ability for the government to see you everywhere so that they know you are doing their own. And they will also do your own too. Balance between cost and utilization. Need for regular actuarial reviews to maintain sustainability. Yes, we just discussed it now that, you see, if I have a report from any hospital that tells me that it has a utilization rate of 70%, 80%, I won't be comfortable because that hospital will not be making profit. Will not be making profit. So a lot of time, I will set up a mechanism to review what is going on there. And most of the time, you find out that they are cooking up data. I'm comfortable with any utilization rate of 15 to 25% because that is what shows that the hospital will be making profit and that people are getting well treated, and that is why they are not going to attend hospital too often. So we should balance between the cost and the utilization, but we have to be careful for some unsuspecting facilities that will have to increase their data because they want to get sympathy, especially when it comes to the issue of fee for service, when you have to pay them. I gave the example of one hospital that was disturbing me that he wanted the code for acute appendicitis. I said, why? I called them at the agency, why are you not giving the code? They said they were suspecting fraudulent, that the system continuously, because it's automated, was continuously rejecting that code offer. And I said, okay, generate a manual code for that person so that I can do the CS. I mean, can do the appendectomy. The following morning, I asked the M&E team to go and visit. They got there, where is the patient you operated? They said they have discharged the patient. I said, and there's the appendectomy for Lana. You have discharged the patient today. So when they called me, I said, ask for the case note, and then snapped the case note and sent to me. They said the patient took the case note away. So we have to sanction the hospital. So that's all from table 2.
Thank you very much, sir. So please, we would collect the write-up, sir. So group question 3. Question 3. Okay, thank you. 5 minutes, please.
Thank you. We will not take time. We have to look at service delivery and supply chain issues, under which
Oh, that's number 6. Yeah, your group 3. Please, question 3. Please, can you project the question? Oh, okay. So that's infrastructure and human resources. Please, what group is that? Is that your group? Oh, okay. Thank you.
Thank you very much. So, in our group, we identified these problems: healthcare worker shortage, brain drain, facility capacity, equipment gaps, physical infrastructure, and supply side capacity. And we grouped the solutions into 3 different categories to proffer solutions to human resource, infrastructure, and capacity building. So for human resource, we came up with the following solutions: increased funding to the health sector vis-a-vis increased salary and welfare for healthcare workers. So we discovered that the reason there is a lot of brain drain and healthcare worker shortage is because there are not enough attractive incentives to keep them in the system. And so increased salary and welfare for them will be able to retain them in the system. And then healthcare worker population mapping. So as these healthcare workers are leaving the system, whether due to resignation or retirement, so we can do a population mapping so that we know how many healthcare workers are in the system per time. And also, there are some local governments that are relatively oversaturated and some that, that have critical shortage. So when we do a population mapping to know how many healthcare workers are in the system per time, that way, due to we can know how many healthcare workers are in the system per time. So we can do a population mapping. We know their cadre and the number of healthcare workers, as well as facility distribution. And also deliberate training of paramedicals. So when we train non-physician clinicians and frontline workers to also support in health resources. And deliberate training of medical science students through federal government funding. So give scholarships to medical students so that the medical science courses can be more attractive and we can be able to get more people into the system. And then for infrastructure, increased government funding. We need more funding allocated to infrastructure. So a lot of existing structures in the facilities are dilapidated. They are in very poor conditions. A lot of them have lack basic amenities such as electricity and water. And also public-private partnerships. So if we can get financial institutions and donor agencies to procure equipment for us, for example, these MRI machines, if we can be able to get them at discounted prices. And as well, increased budget allocation and release of funds. So it's not just for us to come up with a budget. Let there actually be release of funds, because so many times we talk about budget allocation, we are allocating so and so billion to this, but we don't see any funds at the end of the day. So not just budget allocation, but emphasis on release of funds. And then for capacity building, public-private partnerships for training healthcare workers, because a lot of healthcare workers lack basic, proper understanding of health insurance policies and its operations. So if you can have regular training sessions for these healthcare workers to be able to understand basic health insurance, because so many people are in the hospitals, doctors, all they just do is to attend to enrollees, but they don't know the basic, the ABCs, the 1, 2, 3s of health insurance, the operations and the policies. So if you can focus on building partnerships for training of healthcare workers, then it can be able to curb the issues of capacity building. Thank you very much.
Thank you very much. Question 4. Yes, please. Question 4. Okay, public awareness and participation. Yeah, I think most of the states had this challenge.
I want to say good afternoon once again. I'm presenting on behalf of Group 4, that is to attend to question 4. Word 4, okay, facility 4. Yes, they've helped us to identify the challenges. So that has really made the work very simple and very easy. So what we just did was to profile solutions. And you can agree with me that what we have here is what we even have at on our table. And the problem is not, or the challenge is not only peculiar to a particular state. And low awareness, education gap, voluntary participation, payment, participation. In our group, unanimously, we agree on the following points. Having identified the gaps, limited public knowledge about the existence, we not want to explain details since there's no time. I will just have to read through what we've been able to bring together as the immediate solution. Number 1, low awareness. What are the recommendations from our group? Launch a sustained public awareness campaign across radio, TV, social media, tankrayas, and local events in indigenous languages. So there is no point in having IEC materials configured in English and you are giving to somebody who cannot even write and read. 2, you have to partner with traditional and religious leaders to act as community champions. We understood the fact that most of our members, they have preference and honor to the pastors, to the reverend fathers, and to the imam. And some of these messages, if it is well passed on Friday during Jumat and the Sunday service, as part of the firm announcement, it goes a long way. Number 3, we have to create health insurance awareness weeks with outreach in markets, churches, mosques, and motor park. Then number 2, the second challenge, education gap. The way forward, develop and distribute pictorial and simplified IEC materials tailored for different literacy levels. Number 2, we need to incorporate health insurance education into community health talks. We are even suggesting that through the health insurance body to the Ministry of Education, even at our state, health insurance program could be part of what is in the curriculum. They will be taught, and they will know it from the grassroots. Incorporate health insurance education into community health talks at primary health centers, schools, and cooperative meetings. And we need to organize focus group sessions in rural and peri-urban areas to correct misconceptions and educate on benefit of procedures. While we were discussing this in my group, sorry for expatiating on this because of our time, there was a time a pregnant woman who was pregnant at the point of being put to bed, and she gave, probably because of these cultural factors or barriers, she said in their own tribe, they will not deliver, in a place, a facility that is covered. Yes. Like where we had now is covered, and this is going to deliver Oma Lobito open, under open level, open roof. And that orientation must change. And there's another woman, at a point when she wanted to deliver, they will have to dig a small hole. They will have to dig a small hole, and she will sit inside that hole. And if that is not done, it doesn't matter the number of medical doctors, the consultants, or the nurses surrounding her, she won't comply. She will have to do and that is just the culture. So we have to change that. Voluntary participation is another gap. Way forward, transition to group-based mandatory roles, enrollment, through cooperative, artisan unions, trade unions. Provide incentives for early and group enrollment, such as family discounts, or 1 free quarter or full year payment. And 4, we need to introduce policy-backed enrollment requirements for certain government services or business license, e.g. market, store allocation. And finally, the payment reluctance. As a gap, offer flexible payment options like daily, weekly, monthly, through mobile money, agent and health facilities. 2, use a pay-as-you-go model for informal workers backed by a robust ICT system. Introduce co-sponsorship schemes through local governments, donor agencies, and philanthropists for vulnerable households. And on the final note, establish a transparent feedback and service quality monitoring system to build trust. To build trust, and I repeat, to build trust in value for money. Thank you.
Thank you very much. Question 5. I don't understand. Okay. Thank you.
Thank you. So on our question is on implementation and regulatory issues. For the first one, enforcement challenges. We all know that health insurance is a game of number. So what we have presently is more or less voluntary. So government have to find a way to enforce the mandatoriness of health insurance. This is the only way we can make it work. Because what we see is that, yes, the law is there, but it's like government is afraid. Because what politicians do is they promise heaven and earth. And in getting votes, they've gone to different associations, promising them. And we know in Nigeria that once you win the first election, once you get into office, you start planning for the next one. So most times it's like they don't want to rock the boat. But for insurance, it's a game of number. We need to find a way to get everybody on board. All we are saying here, assuming we have like 50% of the population of the Southwest on the scheme, I believe we will not be here saying this. So we need to get government to use their political will to make the scheme work across the region. For system integration, the issue is we need to have a harmonized benefit package for the scheme across the region. That's one way the scheme will work. You can have different benefit packages across each state. How are we going to implement that? But if we have a harmonized benefit package, and probably going with that will be a harmonized tariff. Because for hospitals, they're out there, they're out for business. They can't get, you can't carry out a service, a different price in Lagos, and when you come to Ondo State, another price. Hospitals will always compare. But if you have a harmonized tariff, it will help, and they will be more encouraged to take part in the scheme. For quality assurance, what we do in Oyo State, first thing, all hospitals must meet a minimum standard. They must meet a minimum. I know when you are in Rome, you behave like a Roman. You cannot get things probably the way it is in Lagos across the region. But health is a unique sector. There is a minimum standard that must be met by all providers involved. And to ensure this, we must involve all stakeholders in quality assurance. What we do in Oyo State, I said that yesterday also, going on quality assurance, we involve staff from the Hospital Management Board, NORGE, and even the NUC. These are stakeholders in the business. So we go on quality assurance visits together. So they see what's on ground. So that when we are pushing from our end, they too are pushing because we are both stakeholders in the healthcare delivery system. For capacity building, it's an ongoing thing. Periodically, we must enforce capacity building mechanisms that we train everybody involved. New things come up all the time. Everybody must be carried along so that once all hands are on deck, we will get the result we want. And for data management, yes, we get to the level where we can harmonize data. But for now, from yesterday, I learned that most state agencies have call centers. So to make it work, and because of data issue, each of these agencies' call center must be empowered to attend to calls. Because when you go to any of the hospitals, except we are giving the hospitals a blanket check that anybody that comes in with the ID card of any of the states should be attended to. But where they need to verify the authenticity of that ID card, the call centers must be able to check the data to affirm that the person carrying the card, the scheme is still active. And that is on the go. Once they do that, and most HMOs do it under NHIS, you call, some call centers are in Abuja or Lagos, and they will confirm the authenticity of that card and they will have access to care. So once we do all this, it will make the system work. It's about belief. Once that people have belief in the system and they have value for money, it will surely work. Thank you.
very much, sir. And for the last question, question 6. Okay, finally. Thank you.
Good afternoon once again. Our topic is service delivery and supply chain issues. Under it, it's divided into 2: drug availability, high costs, and stockout syndrome. Drug stockout, supply chain challenges, and service delivery. Poor service delivery, systemic challenges. So I will start from the rear. Poor service delivery. Service delivery, there are just mainly 2 components: personnel and drugs availability. So if there are personnel and there are drugs, service delivery is taken care of. So how do you do that? I think during even our press conference, the chairman for the PSHMB mentioned, and that's the solution we preferred, that there should be facility-based recruitment. So if someone is from Ondo or someone is from Irele, for instance in Ondo State, if you are employing, where you ensure that someone from that locality who will not want to go to Akure the next year or the next month should be employed and is resident in that facility. That is the solution, pure solution to that. And again, also incentivize health workers. You agree with me that in most of the hospitals, they are already overwhelmed. And then you're now bringing in insured patients. So the work is much, and they are still the same person attending to these people. So provide incentives to encourage them so that we can retain them. Ondo State government has recently done that, increased worker salary, especially doctors and nurses. Others are still in the pipeline coming. Again, engage NYSC. This is the highest authority, so that they can get more workers retained in the state. Now that now leads to the supply chain issues. The most important thing, when enrollee goes to the facility, when he sees the physician, the other side is that he is given his medications completely. So how do we ensure drugs are available at all times? We discovered there are times some doctors will prescribe branded medications. We say the solution is that we should adhere to the national treatment guideline, domesticating the principle of essential medicines, which means that prescription should be purely based on generic drugs, generic name, no brand. Number 2, we also prefer another solution we preferred was that the insurance agency should work closely with the drugs management agencies in their state. With that, drugs that are available in the system are affordable and of the highest quality, because nobody is buying drug from a vendor or is getting the drugs from the source that you cannot trace. When there are pharmacovigilance issues, they will be able to trace back to the drug management agency where the drugs are gotten from. So agencies, shares should work closely with the drug management system to ensure that drugs are available and of the highest quality. We also suggested that there should be we can do branding of drugs. The shares can brand their drugs, like Ondo State. We can do oranges drugs, which will be provided for all facilities. The other thing Ondo State has done, very importantly, I think during the presentation yesterday, Lagos State also mentioned, is we have what we call pharmacy benefit scheme. There are facilities that always, there will be no drugs at all times. So what we did was to accredit community pharmacies, so that when they go, particularly this one is for secondary drugs only. Because capitation has been prepaid to facilities for primary services. So you don't expect that prescription will go out of the facility for primary drugs. What we do is we ensure when the enrollee gets to the facility, especially those on chronic conditions like hypertension and diabetes, if it is not available, the prescription is sent out to the accredited pharmacy, community pharmacies, we authorize. By so doing, drugs are available to our enrollees at all times. There will be no time I will say, I go to the facility, drugs were not given. If the drug is not available, you get an authorization, you go to an accredited community pharmacy, and we give a drug and we pay the pharmacy. One very important factor, again, is effective monitoring and evaluation. The agencies will do their part. All agencies, I think, have monitoring and evaluation units and also quality assurance units. So periodically, they go for monitoring and evaluation. Again, at the top level, I think the last speaker also mentioned, there should be integrated leadership involving the top level monitoring, which means all the permanent secretaries in the health sector, labor leaders, board members of the HMB, Primary Healthcare Development Agency, all of them will go to this facility quarterly to see what they are doing. Because if capitation is paid as and when due, your fee for service is paid, is not being owed, then what other reason will you be able to give that you do not have drugs or there is out of stock in the system? Thank you very much.
Thank you very much, sir. Thank you to all the groups for doing justice to the questions and preferring solutions. So we'd like to open the floor for extra feedback, comments from other groups to the other questions, if we have anybody. Thank you. Please, can you project the questions? Yes, if you have other feedback outside of this, please would appreciate that.
Thank you. I thought about it. Graciously, NHI has increased capitation rate in the last year, which has put serious pressure on the state health insurance agencies, because most of the facilities will refer to your capitation as when NHI is paying 1,400 and something, you are coming to tell us that with the inflation rate, the current economy, how do you want us to take that as capitation? So we are finding there is this pressure to increase capitation at all times because NHI has increased theirs. The shares now, it is done. What can we do so that this pressure, the agencies can come together and decide on one thing? That's my question. Thank you.
Okay. Okay, sir, I'm coming.
Thank you, sir. On the issue of availability of drugs, since we have the Southwest people here, is it not possible for us to come together? Because if we have a way of meeting the manufacturers, that they can produce drug in large quantity for the Southwest, it's going to make the cost of our drug cheaper than go individually. Because the moment you have markets and you are sure, and those companies they are sure that, oh, these people, the Southwest people are coming to buy drug from them, definitely the drug price will reduce. So we should think along that way when it comes to integration. It should not be done in isolation. The DMA of the Southwest can also meet so that we can begin to put something in place so that the drug, the quality, the price of the drugs can come down, and that will benefit the system. Thank you.
Because you speak to what Dawn Commission is set up to do. You know, like I said, Dawn Commission is set up to do this regional integration and cooperation and collaboration. I know that I tell people always that one of the subjects that we should introduce in our elementary school is collaboration. I think we struggle with it, with collaborations. You know, we have proliferation of everything. Is there political parties? We have about, I've even lost count of number of political parties we have. Is it church? Is it businesses? You know, we don't enjoy the economy of scale because we like to do individual stuff. We cannot collaborate, and that's what the Commission is trying to achieve. That question is very, very important, and we are taking some things away from this place. We also have institutions in Southwest that are doing things in silos, and we can come together. For instance, Ondo Investment Company is Southwest company, and recently they've gone into pharmaceutical sector. So that thing you mentioned now is a thing that we can approach them and say, okay, what exactly do you want to do within this space? And this is Southwest Drug Administration and stuff. How can we go about it? So, but the problem is, are we on the same page for this collaboration and integration, or we are contented with the space that we are managing? Well, let me tell you a joke which I corrected him yesterday when we were reviewing his presentation. I mean the Dr. Olumide, and I corrected. I said you should not say it. That's why I didn't say it today. But he stylishly said it. But you will not understand because you don't have that convention. He was saying that why not just have one entity? As I teach, I mean, it's not possible in Nigeria because there's no regional government. Every state is independent, but there could be a way to collaborate. You know, the same thing we did at Amotekun. Amotekun idea came from our office, you know, and in order, when federal government started talking about there cannot be regional police, okay, so the governor decided, okay, let each state go and pass the law, you know. So the law in every state as to Amotekun is the same because the Attorney General came together to draft the law, and then National House of Assembly also came to pass the law. So the law, Amotekun law in Ekiti, is the same with Amotekun law in Ondo State. So what I'm saying is saying, if we agree to collaborate, you know, to integrate some of those, we can enjoy the economy of scale. The group 5 mentioned the issue of some of the challenges to integration. It's something that we can sit down and think around it, how to manage those things, because cost of living in Lagos is not the same in cost of living in Ekiti State. So we need to find a way to sit down. But if you are willing, you know, to sit down and think about it, and you can have solutions to that thing. I just want to say that if you leave this room thinking collaboration, integration, some of those issues can be resolved. When we get back to office now, one of our next steps is to also give this feedback to Ondo Investment Company and see maybe there's going to be a meeting, you know, with the state on how this partnership can work. But it's because the states are sovereign, they are independent. Even though we are all Southwest, but the states, they are independent. So if they don't want to collaborate or cooperate, then there's nothing anybody can do. But that mindset, if you can grow that mindset of collaboration, cooperation, and integration, then it will help us to achieve some of those things. Thank you. Sorry, I don't know who wants to respond to our brother's question. Spoke about NHIA increasing capitation 1.4, but the states are paying 1,000, and there's a pressure. Okay, sir.
Please, do we still have the rep from NHIA in the office in this? Okay, thank you. I think the issue of NHIA and the State Social Health Insurance Agency is having differential capitation rates is not strange. As much as we'll have loved for us to have a synchronized ratings, but NHIA has gone ahead to increase their capitation rate, which eventually led to them also increasing their premium for their plans. I will not struggle with that. I think it's a conversation we'll still have at the national level to see how can we work together to ensure that whatever we do not have adverse impacts on the coverage at the state level. Be that as it may, somebody mentioned the issue of how do we have integration across the Southwest? And I will take it beyond the Southwest and also talk about at the national level. One thing is sure, the hospitals, both government and private, across the nation have NHIS enrollees. And they also have NHIS tariff. I think what we can agree, can we adopt that tariff when we want to do integration? Because a hospital in Osun accepted that tariff, hospital in Lagos accepted that tariff, hospital in Ondo accepted that tariff, hospital in Ekiti, same, hospital in Ogun, hospital in Oyo. So we can have that conversation that do we adopt that NHIS drug and service tariff? I'm not talking capitation now. Everybody can have their own differential capitation based on where they reside. What people pay in Lagos is different from what we pay as premium in Ondo. If we can come to that conclusion, it will simplify what we want to achieve for two reasons. Number one, if we use differential tariff rates, it puts unnecessary administrative burden on also the hospitals to do billing, claims, fee for service become a bit stressful for them. So it becomes something that is regularized across the country. So if you move from Ondo to anywhere, then they apply the tariff. And that we solve a lot of problems. But in terms of capitation, everybody can use their own capitation. Well, capitation is a matter of number also. NHI is increasing capitation because they have very little number. If you don't have the number, economy of scale, you cannot negotiate with the hospital. In Ondo State, NHI have roughly 68,000 enrollees, while we have over 240,000. So we can negotiate better. We cannot pay the same capitation rate that NHI is paying, and it's okay for us. So I think that would be my recommendation. It's a conversation that we need to take further and ensure that we make things easy for the hospitals to be able to work and work effectively. Secondly, we talked about integration. I think we should not fragment. The biggest customers to the DMAs are also the health insurance. So anytime we're having this kind of regional roundtable, summit, or conference, then we should also be in the same room, both DMA and the shares, so that it makes life very easy, so that we don't have different conversations at different times, because there are suppliers where there are customers. And if we also want to have health sector integration, it could be biannual or annually, then all of us in the health sector must be in the same room, from the Honorable Commissioner, the SA, the Permanent Secretary, so the SACA, Primary Health Care, Insurance, DMA. It makes the conversation a bit more robust, because as my PS is beside me now, I have limited influence on human resource for health in the state. He is the one saddled with that responsibility, and also the coordinating ministry, which is the Ministry of Health. So it becomes a bit more robust when the delegation from the state have all the major stakeholders on the table, so that issues that are raised can be addressed, recommendations that are made, we can take it home, we can domesticate, and it will make life very easy. Thank you.
Thank you very, very much, sir. And that would bring us to... Oh, okay. Sorry, sir.
Good afternoon, everyone. I just said, well, as a form of closing remarks from Ogun State, let me just quickly touch on one or two things that has been said, and also touch on some things that have not been said. But I think in deciding that I was going to speak, my very good friend from Ondo State must have spied my list here, because he started now mentioning the things that I've written down. The That's also an option or a possibility. But I think it's the other way around. Now, on a serious note, I don't think anybody should be threatened by this issue of differentials in capitations between NHIA and the states. Because frankly speaking, my position is this. You've talked to the healthcare providers, they've agreed on your capitation, and probably they've signed an SLA or an MOU with you before they move forward with you. So they should not do any comparison. Because the other thing is also what my very good friend has said, is this economy of scale that you have brought to the table. The NHIA that they are just using to tell you, go and ask them. I know some of those facilities that have just maybe 15, 10, 20, 15 NHIA enrollee with them, which is the reason why they need that high capitation. You on your own part, you've probably given them about 500 or 1,000 or even more. And so whatever capitation you are giving them should be enough. Nobody should put under any pressure or the other. I also think that what NHIA should do, there shouldn't be one capitation for the whole country. I remember we were, just like this conversation about minimum wage and states being able to afford it or not and things like that. We will get there sooner or later. There should be a minimum somewhere, but let everybody pay what they can pay. I remember we were in a workshop in Lagos by the World Bank, and they were now discussing this issue of capitations and premium and tariffs and so on and so forth. And they put, you know what these people did? They decided to, I said, what if we give you a tariff of, for example, X naira, and everybody was just complaining. And I stood and I said, no, it cannot work. And how can you say X naira? What we're even collecting presently is X plus 500 naira and so on and so forth. And I'm sorry to mention names. And I remember my counterpart from Taraba just stood up and said, this money is even more than what we are charging currently. You know Taraba, the short man, he has retired now. And the whole room went silent. What's this man saying? He said, well, all these things that all of you are saying since me, I don't understand you. That he said that CS is 200,000 in your state. That is 25,000 in Taraba. This was something somebody said about 3 years ago, and I'm serious. And we are like, CS is 25,000 naira. And he was giving some examples like that. And that's, well, so what the World Bank is putting on the table is more than enough for them. That's this one that we are complaining of a capitation of 500 naira then. That's for them, they don't have any problem with it. They can even do less than that and so on and so forth. So my point is that let every state, because there are different standards of living, it's as simple. And when you now marry it with the purchasing power of the states, there's also something called that. 10,000 naira in Lagos is not 10,000 naira in Ondo or Ogun State. That is the truth. And that 10,000 naira is not also the same thing. We were in Borno State for NCH last. And I just called one of the people in the hotel to come and iron, and the guy went and came back. I said, how much is it? He said 300 naira. Top. And a complete. And I'm serious. That was what happened in Borno. And I said 300 naira to iron. So purchasing power is also different. So capitations, let everybody move with what they are comfortable with when they look at all those their parameters. I just want to introduce this issue of drugs. Because you see, most of the times in gatherings like this, I keep quiet because I have this orientation of that sometimes we know the solutions, then we discuss all the other ones and leave the solutions undiscussed or untouched. Most of the problems you're having in that sector, the health insurance ecosystem, can be solved if federal does what they're expected to do. And what do I mean by that? Professor Sambo tried during his period, and they did a lot of work, calling I think 14 or 15 pharmaceutical companies together, and they were getting beautiful prices. It's all about economy of scale. You can imagine when they had that discussion with them, they say, don't worry, Ogun State will buy 1,000, or will buy 1,000, Ondo will buy 1,000, and things like that. And we will assure you that everybody will buy those drugs from you. And so they were giving them crazy low prices that none of the states could do. But of course, where he missed it was when they now said they were going to brand the drugs NHIA. So we, the forum of CEOs, just, no, it's not going to happen. Why should I take drug that I say not for sale, NHIA or something, and be giving to Oxshire patients or enrollees? And we were at that junction before change of government and something else happen. I know currently that the current administration is also doing something called Medipool. And that's what they need to do as quickly as possible. Some of these things shouldn't take time. If they do it and they get it right, and they push it out there, and they allow that, okay, you've talked to Fitzin and M&B and things like that, you get a price that even the DMAs will not get. Then let the DMAs now go and pick those drugs that you've agreed at that point, and then give it to DMA, and then give it to us. Then most of all these things that we are discussing, we won't be having these discussions. I just want to put that on the table, let it reflect somewhere, so that somebody will quickly work on some of these solutions that it needs to work with. We all know that one of the major critical success factor in insurance is drugs. No matter what you do to non-enrollees, if they don't go with a bag full of drugs, they don't feel that you've done anything. And the cheaper the drug gets to you, the healthcare provider, the better for you. Because what eats capitation up is drugs. I tell them that, see, leave all these ones, and we are seeing a lot of patients. You still pay your staff salaries. You still pay for your NEPA bill. You still pay for water and things like that. But after buying drugs, whatever remains from your capitation, just take it as your profit and so on and so forth. So if you can crash the prices of these drugs, it will really help insurance a lot. And this emphasis on we need to increase tariff, we need to increase premium and things like that, we reduce a little bit. Well, that is my feeling. Okay, this is also something I tell people. You've asked me to go and start looking for enrollees. You've asked Dr. Oyenei to go and start, Zamba to go and so on and so forth. Why doesn't the federal government make health insurance the same way that it's happening in car insurance? It can be done. Why am I doing awareness? I'm sitting down with and this is what we do. The Bricklayer Association, the Painter Association, this one and that one, Artisan Association of Nigeria, you talk to these people, you talk to that, you visit companies, and everybody's there, okay, we'll get back to you, and so on and so forth. Why not one federal government policy that's insurance? All the law says that health insurance is mandatory. So why is somebody up there not helping us to enforce it? And then say you cannot do business in Nigeria unless your staffs have insurance. You cannot do this unless you have insurance. You cannot process your BVN unless you have health insurance. Then the figures are there. And then most of all this problem gets solved. Because I tell people, there are 7 million people in Ogun State. If all the 7 million are giving me 1,000 every month, that's 7 billion naira. And then I can do a lot. And most of all this other, even the facilities that are complaining of the premium will no longer complain when you move their enrollees from 500 to 5,000. I don't know whether we get that picture. So the person getting 250,000 naira will now start getting 2.5 million. He will stop complaining. Because then you have reduced adverse selection to the minimum. The people doing insurance currently now are usually 80% adverse selection. What do I mean by adverse selection? They already have an existing morbidity before they come and do your insurance. But if somebody enforces it and then everybody's on insurance, then you've reduced it, you've watered it down, and then when you now give them 5,000 enrollees, it's only what the study says, only about 5 to 10 or 15% maximum will visit the facility. Unlike now, go and look at your data for civil servants. Almost 60 or 70% are going to those facilities every month because they are mostly hypertensive or diabetes and so on and so forth. So, if we know that we are really sure, that's exactly what we need to do. Then we also need to integrate health insurance. It's madness moving from one state to the other, and we all have different tariffs, different plans, different this, different that. After the federal government has helped us with the mandatory nature of health insurance, that's the next thing we need to talk about. Every state can have its own plan or program or tariffs and so on and so forth, but there must be a national one that has a national premium, a national plan, a national tariff, so that you have a national card that wherever you go in the country, those are part of the things that you make people quickly come on board and they want to do the insurance because they then know that they are covered. Not like the one that we are selling now, and let me give you an example. The state says we have about 5 hospitals in each local government. So even the people doing the insurance knows that the geographical coverage is not there. what happens when I fall down and I need emergency services in, how many people knows about Ogun State now? In Idiroko, and I don't have any facilities in Idiroko. The insurance is not really covered. Well, I just want to put those ones for us to put our thinking caps on. Thank you very much.
Thank you very, very much. Okay. This last one, sir.
Okay. Okay. My own submission have been, over the time, I've been insisting that why is NHI still having a relief? That's supposed to be a regulatory agency. Because that's the problem. Because they are working federal staffs, you must hold on to that regulatory function. You can't be a player at the same time be a regulator. Yes, they should, and every federal government really put it to the states. Let's develop this country together. We can't be insisting that because there's a monetary value for it. But then we must look to the future. If there's no point, you still insist, you have your enrollee and insist and be a regulator. How will you be able to regulate when you're also a player? My position is that, please, we can, it may not be now, but let's begin to look at it. There's no reason why NHIA should be even an enrollee. Let's put all the enrollee in federal, in the state, on those states. Put it in on this Contributory Commission, and you regulate them. And then they can have a large pool. They can get their own premium. Or you can even, you see, you can insist that all the premium can be in the same in the state when you can do that and release to the states. That's just my own submission.
Thank you very much. So this will be the last person for this session. Thank you, sir.
Thank you very much. My name is Ayodele Babatunde, representing NHI Ondo State. I'm actually representing my state coordinator. First and foremost, I want to join others who have applauded Dan Commission for this conference. It's a very important conference, and I've really learned a lot in this gathering. And I'm sure if well implemented, is going to helping us achieving universal health coverage in the southwest region of the country. And I also want to go in line with what Dr. Yenai said regarding bringing stakeholders together, let's say annually or biannually. And I want to suggest that instead of having Southwest Regional Health Conference, maybe we target, going forward, we target annual Southwest Regional Health Insurance Conference. So the Dan Commission can look into that so that it can be a rotating where we can bring all the stakeholders together and brainstorm. And of course, review our progress. Back to what Baba said. We all know that is a law that establishes NHIS, and there's a heart guiding it. And you are right, sir, when you say we don't have business with running health insurance in a way. But again, what the law says, if I'm correct now, it says we are responsible to cater for the federal civil servants. And I know there's talk ongoing as regards the private program that we run, which is called GiveShip. I know that my director has discussed that with the DG, and talk is still ongoing on that. Then during the course of presentation of all the state agencies, I saw that there's this, let me put this allegation of not payment of basic healthcare provision counterpart funds. Part of my report yesterday when I left this place, I reported to my coordinator and I told him that this is what they said. And of course, they are aware. The DG is aware. And I told him because they are in a place together in Lagos for retreats. And I said, please kindly remind the DG and said this is the allegation that the federal government is not paying counterpart funding, and he said he's going to do that. So, and I'm sure he has done that. So, and maybe any moment we're going to get the money. Thank you.
Thank you very much for all the comments and feedback that we have gotten. We will now be closing this session, and I'll be handing the mic over.
All right, thank you so much, Maiwa. Thank you so much. I think we want to leave here by 2 because some of us are still going a bit far. Yes, so we listen to everything and just kind of next step. I think, I don't know if Dr. Yunani that said so about meeting all the health sector practitioners in the room. I think Dawn Commission is currently planning to have that health conference. Maybe if everything works out as planned, it will happen this year. And we are bringing all the sectors, all the participants or practitioners in the health sector into the room to discuss some of those issues. Because Dawn Commission, we work with some experts led by Professor Adewale, to the former Minister of Health, to develop what we call Southwest Health Blueprint. The document is ready. We've not been able to launch the document, and so we want to use that opportunity of that Health Conference to launch the document. So we're looking forward to host that event by the end of this year, before the end of this year. And of course, everybody in the room will be invited. And secondly, the issue of the annual that let's talk about is something that we'll look into to make it annual event. But in between that annual event, there will be short meetings to discuss some crucial issues that will come up in the course of the year. So that will also happen. And for us, one of the takeaways from this place is we'll continue to pursue that path for that regional cooperation and integration in the health insurance sector. And secondly, there is also Southwest Development Commission they should start operation very soon. And from my discussion with Dr. Olumide Okunla, I said that other regions, other commissions in other regions, they are actually funding health insurance through by taking up policy for lives, but they make use of that social register. So that's why we need to tidy that social register. So please, Dawn Commission will call a meeting of the managers of that social register in Southwest so that we can look at it. And because they are federal government agencies, and if federal government is using that social register, the SWDC, the Southwest Development Commission, will definitely use the social register too. So we'll look at it and then do whatever suggestion that I've suggested, that I've brought up here, to see how we can get it ready, so that when the Southwest Development Commission start their operation, fortunately they are looking at Cocoa House, where our office is located also. So we are going to be neighbors here in Cocoa House. So it's possible for us to do that. So maybe they will also have cause to meet with the head of health insurance, because we'll pitch that to them. So that's why there's a need for us to be able to clean up those registers and use it to engage them, and then maybe we'll get it. Because one of the pillars of Southwest Development Commission is social and human development pillar. They have social and human development pillar, so it means that they are going to be involved in education in health issues. So we should get ready for that. So for our own part, we'll go back and work on some of the things that have been said. We'll try and reach out to the governors about some of these resolutions in this place. The governor should be meeting very soon. So we will try and present some of the resolution here to the governors and see how we can take that on board. We want to sincerely appreciate everyone that have made it here and have stayed this far, for this 2 days event. We really appreciate, and in particular, the host states and Dr. Oyinleyin in particular for doing this. And I want to approach other states also to help us host this very soon. I think the Ondo state has set the pace, even though they are not the pace setter state, but they have set the pace, and we hope that other states will be able to match up with them. Thank you so much. We appreciate from Dawn Commission. We send our regards from the DG Dawn Commission. So thank you, and have a safe trip back home.
Thank you very much. A round of applause for Mr. Alajipo, who has represented the Director General of the Dawn Commission. very well here. A round of applause for him, ladies and gentlemen. Thank you very much. Distinguished ladies and gentlemen, at this juncture, we have come to the end of this 2-day impactful and enlightening conference. Thank all of you for your time, for your enthusiasm, and for your collaboration toward the success of this conference. And to formally appreciate all of us is the passionate and highly cerebral Director General, Ondo State Contributory Health Commission, Dr. Abiodun Oyeneyin. A round of applause for him, ladies and gentlemen. After his speech or comments or whatever, we say the grace and we take photo sessions. Thank you very much.
Distinguished delegates, ladies and gentlemen, for want of time, just allow me to just give the vote of thanks. I think we've had enough remarks, and it has been a very successful event. We thank God Almighty for helping us see to the success of this very important conference, first of its kind. Let me start by appreciating His Excellency, Dr. Lucky Yorimiso Ayedatiwa, for the support that we enjoyed to be able to host this very important conference. I thank the representative of Mr. Governor, the Special Advisor on Health, Professor Simidele Odimayo. I thank immensely the Secretary to the State Government, Dr. Taiwo Fashionroti, also ably represented by the PS Guard. The Head of Service, who currently is attending a state function outside the state, also sent the representatives, which is the Permanent Secretary, Ministry of Health, Dr. Niro Ikuomola. Let me thank our board members in our midst. We really appreciate you for being with us yesterday and today. To the DG of Dawn Commission, the convener, and your team, we really appreciate you. We really appreciate that we are having regional integration, and we know this will be expanded to ensure that the Southwest continue to fulfill its mandate in terms of health and also bringing shared prosperity to our people. I would like to thank especially the Honorable Commissioner for Health, Osun State, who was with us yesterday and had to also leave to attend to other important functions. To all our permanent secretaries, starting with the Permanent Secretary Hospitals Management Board, Dr. Adiji. We thank you so much, sir. The Permanent Secretary Local Government Service Commission was also in our midst. We thank immensely the #1 doctor in the state, Dr. Alonge, the NMA chairman. Let me use this opportunity to thank all the delegates from the southwestern state, starting from Lagos State, led by Dr. Samba, fully represented here. Lagos and your team, we appreciate you and we wish you a safe trip back home. We thank the delegates from Ogun, led by Dr. Afolabi Dosumo, the Executive Secretary. We thank you so much. We thank the delegates from Ekiti, led by Dr. Doherty. We thank the delegates from Oyo. We thank the delegates from, which one is left? Osun, Dr. Akindele, led by the Honorable Commissioner for Health. Special greetings to our Honorable Commissioner, we really appreciate. And the host, this is Ondo. I thank all the delegates from Ondo, but that will not be complete without thanking specially someone that have been of great support to the Ondo State Contributory Health Commission, the Director, Health Planning, Research and Statistics, Dr. Adesoji. We really thank you so much, sir. Dr. Adelusi was also with us. Famlash was also with us. All the directors of the Ondo State Contributory Health Commission, the staff, and the management. Famlash, I can see that you are still with us. But Lagos will not take you away from Ondo State. You are still part and parcel of Ondo State. The Director, Planning, Research and Statistics of the Hospitals Management Board, our own Dr. Abe, we appreciate you. The organized labor leaders, I'm quite excited, I'm impressed. From NLC, TUC, GNC, NOLGE, we really, really appreciate you. We have enjoyed so much support from them because without collaboration, we will not have our former sector under the health insurance cover. To our CSOs, the chief himself, seated since yesterday, there will be more collaboration, sir, because we have a major role to play in advancing health insurance, especially in the informal sector. Your team, representatives of OD-SACA, we really appreciate you. Please help us thank the PM, OD-SACA, Dr. Adegbulu. We really appreciate you. I hope I've not left anyone behind. Trying to scan the room. You know, Lagos taught us that we must have a helicopter view. So I'm trying to scan, to scope, to see that we've not left any. The ES, Drug Management Agency, you people did not help me at all. We must thank you. And something that featured greatly was availability of drugs. And I hope that we collaborate with the drug management agencies across the Southwest to ensure that we make drugs very much available to our people. The chairman ODRS was with us during the press conference. I thank him immensely. SSA Artisans, I think he was represented yesterday, and we really appreciate his being with us. I thank the special advisor especially for the role that he played, both representing Mr. Governor and also being our supervisor, and the SA to the special advisor, Dr. Dolani Belela. He was with us. We really, really appreciate you. Mrs. Stella Nathaniel, we appreciate you for also being with us, sitting closely to Chief Akomolafe, our own chief. I think he's the only chief in the room. Thank you so much, sir. We really, really, really appreciate you. NHIA, Mr. Yodele Babatunde, thank you so much. This week they were having a management retreat in Lagos. That's why the state coordinator, and he sent his apologies. The DG also sent his apologies. Would have loved to be part of us. We thank Emerald Expressions for those lofty songs and the team song. We really appreciate. We thank the media. We thank the ICT team. We thank Dr. Okwala for the 2 days, the presentations. I'm going to study the presentation seriously. And also the representatives of UNICEF. We thank him for also joining the meeting. To our online audience, we thank you so much. And we hope that when next we'll be having this again, it's not going to be annual. We're going to have it very regularly. It could be quarterly or biannual. And it will be more of a Southwest Health Sector Summit. Healthcare under one roof, where we bring all the stakeholders under one roof and ensure that we advance the cause of attainment of UHC in the Southwest and by extension, Nigeria. I like to specially thank the organizing committee of the Ondo State Contributory Health Commission for putting together this wonderful conference. Can we give them a round of applause? And by extension, all directors, management team, heads of departments, heads of units, all our core members, our IT students that contributed immensely to see that this program is successful. Thank you so much, and I wish everyone safe journey back to your destination, and we hope to see you very soon, wherever the meeting will be taking place. Thank you so much, and God bless you all.
Thank you very much. A round of applause for Dr. Yenei once again, ladies and gentlemen. Thank you very much. Don't forget, at the end of the program, we have photo sessions. Thank you very much. My name is Delia Ugwami. I'm from the Ondo State Ministry of Information and Orientation. I'm a director in the ministry. And I thank Dr. Yenei for the opportunity to be the master of the ceremony. Thank you very much. Shall you please rise as we say the grace in unison? After that, we'll take photo sessions. Thank you. May the grace of our Lord Jesus Christ, the love of God, and the sweet fellowship of the Holy Spirit be with us now and forevermore. Amen. Praise the Lord. Thank you very much, sir. So, the executive secretaries, the permanent secretaries, please, you come up here for the photo sessions, please. I will be announcing according to the way the photo sessions will take place. Thank you very much. Let the executive secretaries, the PS, come and join the DG here for the first one. Please. I agree. Please, the board members, HMD, please, you come and take the next photo session. Yeah, take that one quickly. We don't have time. Yeah, thank you. Simon was. John Commission, please come. Town Commission. Sotia. Thank you. John Commission. NMA. NMA. Dr. Abi. Dr. Abi. Ondo State Contributory Health Commission Management of the Ondo State Contributory Health Commission. Mrs. Olakoye, Mr. Olakoye, where are you? The management, OGC, Oyamabo, Mr. Bitoye, you know. Oh, Mr. Bitoye. Mr. Olakoye.